Welcome, everyone. I'm excited to get us started today with a great presenter. We've got Dr. Joseph Muenzer here today to give us an overview of MPS. And for those of you that heard my welcome speech this morning, you heard me speak of it's a 10-year anniversary for our family and our Jack's MPS II diagnosis. And so my first conference was in St. Louis 10 years ago, and we had been 3 weeks out maybe from diagnosis, so very early. And I had the fate of sitting with Dr. Muenzer at a continental breakfast and started chatting with him about my son, Jack. And Jack was diagnosed very late. He was 8.5. And we were seen by a geneticist in New Mexico that had experience with very, very few MPS patients, as most of us have experienced just given this rare disease. And so we were just given some information about Jack's situation that was frankly inaccurate, but we didn't know that at the time. And so I sat with Dr. Muenzer and started telling him our story, and I really got some priceless and life-changing information from him at that breakfast. And it will be something I am forever grateful for. So Dr. Muenzer is just such an amazing individual in our community. And I was just sharing this story with him when we were chatting before this session. And we were commenting, both of us, that I am not alone in those conversations and those interactions that Dr. Muenzer has had with many, many of our families. And so thank you, Dr. Muenzer. Thank you for being here today. And I'm going to just do a quick introduction and give Dr. Muenzer's background for you all. So Dr. Joseph Muenzer is a professor in the Department of Pediatrics and a research professor in the Department of Genetics at the University of North Carolina in Chapel Hill, where he's practiced since 1993. He's actively involved in the diagnosis, management, and treatment of patients with inborn errors in metabolism, especially MPS, and infants defected by tandem mass spectromium newborn screening. Dr. Muenzer received his MD and PhD from Chase Western Reserve University in Cleveland, Ohio, and completed his residency in pediatrics at the University of Wisconsin Hospitals. He did a genetic endocrine fellowship at NIH in Bethesda, Maryland. Dr. Muenzer is a board certified in pediatrics and clinical biochemical molecular genetics. His basic research interests have been focused on the development of AAV gene therapy as a treatment for neurological disease and Hunter syndrome, MPS II. He's created a mouse model for MPS II. His clinical research interests are directed towards the development of enzyme replacement therapy for MPS. He was a principal investigator for the recumbent enzyme replacement clinical trials for MPS I and II, and currently is the principal investigator for a phase 1 and 2 intrathecal enzyme replacement clinical trial for the severe form of MPS II. And that is a long list of amazing accolades for Dr. Muenzer. And again, he's just such an amazing part of our community. And so I want to really encourage the audience to ask questions with this presentation. We do have time at the end for questions. No question is too small, too dumb, too simple. This is exactly what he's here for, and so I encourage you to be active in the virtual question, and we will try and get to as many as possible. And with that, I'll turn it over to Dr. Muenzer.
Well, thank you very much, Lisa, for that very kind introduction. As a lot of you appreciate, having to do this virtually really has its both benefits and limitations. It sort of benefits probably a much wider audience than we can reach otherwise. It's limitations that I can't sit with some of you and just chat and have breakfast. And that sort of, that's something I really love to do, is meet families and sort of help them. Sometimes it's the simple questions that are the big deals for family. In terms of Lisa, issue that she was told her child had severe disease, and in reality, when you just hear the story, that was not the case. So this talk is really geared at a very brief overview and introduction. We're going to focus both on MPS and ML2 and 3 for this presentation. I'm going to sorry. So here's my disclosures. You already heard those disclosures. I'll just skip over that. I consult and serve on a variety of advisory boards, and I'm also involved in a principal investigators for a number of different clinical trials. And I was telling Lisa, my hope is in the next 6 months, I'll be involved in a gene therapy trial for Sanfilippo A, sponsored by Cure Sanfilippo, and a gene therapy trial for MPS II that will be Project Alive will be involved with. So here's what I'm going to do. I'm going to just give you a very brief overview of ML2 and 3, talk about some of the clinical features, and then just spend some time talking about an overview of MPS and just talking about some of the very basic aspects of genetics in that, and then go through the different MPS disorders to show you what they're like and give you some idea of the spectrum. And this is one of the challenges for these diseases, is really the variability, or clinically we call it heterogeneity, the variability within each disorder and across the different MPS disorders. And then at the end, I'll just very briefly give you a treatment options that we currently have, but you'll hear a lot more if you attend the rest of the conference in terms of some of those aspects. So ML2 or ML3 or mucolipidoses, they're a group of lysosomal storage disorders where you're missing a particular enzyme. And you can see the name here, N-acetylglycosamine 1 phosphotransferase, or transferase. And this enzyme is involved in helping get the lysosomal enzymes to the lysosome. And when you're missing this enzyme, what happens is, instead of the enzymes that are made in the cell going to the lysosome within the cell, they get directed to outside the cell, and of course can't be used there. And so we can make the diagnosis fairly easily by finding elevated enzymes outside the cell where they shouldn't be there, and inside the cell, in white cells, they're very low. Like all these, like the MPSs and all the 2 MLs, 2 and 3, these are progressive disorders. That is, with time, they'll get worse because these enzymes we'll be talking about, like this phosphotransferase, is a basic, what I call a housekeeping gene. It's needed to be there. And if you don't have lysosomal enzymes, then you store all sorts of different compounds within the body, and the storage causes ongoing damage. And for those of you who have ML2 and 3, you'll realize within each 2 and 3 there is a variability, and compared 2 to 3, 3 is basically the milder form of ML2 from my perspective. And this is that sort of spectrum of disease of this phosphotransferase. I have shown here in terms of ML2, or eye cell disease, another name for it, very severe cognitive impairment, can have short stature, big tongues, can have bone disease, can have obstructive airway disease we see in the MPSs, have heart involvement, joint stiffness, and unfortunately in the very severe forms, those individuals die by 3 or 4, since we really have no treatment for ML2 or eye cell disease. ML3 tend to have less or to no cognitive impairment. It has less progression of the physical problems. Corneal clouding can be a very prominent feature, joint stiffness and bone involvement. And we also can see significant heart disease with time. And it's a valvular heart disease, similar to what we see in the MPSs. And unfortunately, we can have premature death because of combinations of airway and cardiac disease. Again, for those of you who have ML2, ML3, that's a very short overview. Please, if you want to ask more questions, put those into the chat. I'm going to talk a little more about MPS in terms of some of the issues of genetics, and I'll allude to where they apply to ML2 and ML3, which are both autosomal recessive disorders. That is, both parents have to be carriers, and each time you have a pregnancy together, you have a 1 in 4 chance of having a child with that particular form of disease. So again, the MPSs like ML2 and ML3 are lysosomal storage disorders. We know there's 11 different enzyme deficiencies that comprise 7 different clinical types of MPS. Each individual MPS is incredibly rare, somewhere in the 1 in 100,000, or even less common than that, 1.5 million for some of them. But as an overall aggregate incidence, that is, you put all the MPSs together, it's probably 1 in 20 to 1 in 25,000 births have an MPS. So it's still incredibly rare. There may be 2,000 MPS patients in all of the U.S. The hallmark of these are really these enzymes are involved in the inability to, when you have a deficiency of the MPS enzyme, you cannot break down these complex sugars called glycosaminoglycans. There's different forms in the body. I'll talk about that in a little bit more later. But as these sugars are stored, they set off all sorts of secondary reactions that result in all the clinical pictures I'll show you a little bit. Again, like ML2 and ML3, these are progressive disorders, and virtually every organ system in the body is involved, depending on the nature of the involvement. It can have more central nervous system, more cognitive impairment, or it can have much more physical and no cognitive impairment. I'll show you that. Again, as we showed with ML2 and 3, there's a wide range of clinical involvement in each of the MPS disorders. So what I want to do is just go through this sort of statement and just really highlight it. So MPSs are a group of rare genetic disorders due to deficiency of specific enzymes required for the breakdown of glycosaminoglycans. And I refer to them as GAGs, and they were formerly referred to as mucopolysaccharide, which is incorrect. And this breakdown normally occurs in the lysosome, a particular subcellular component of all cells. So these are rare genetic disorders that they're inherited. And so from almost all of them, ML2 and ML3 are autosomal recessive. That is, both parents have to be carriers, and then there's a 1 in 4 chance with each pregnancy to have an affected child, but there's a 3 out of 4 chance of having a child who's either normal or who's not, or who's a carrier. Where in contrast, MPS II is the only X-linked disorder we're talking about in terms of lysosomal disorders, in terms of MPS. And in this case, the males are affected and females typically are carriers, because in the MPS II gene is located on the X chromosome. And so if you have an affected father, all his daughters would be carriers, but none of his sons would be affected because of the nature of the genetics here. And we can talk more about that in the discussion if we need to. But hopefully, all of you, since you've been diagnosed, have had genetic counseling. And if you haven't had adequate genetic counseling, I encourage you to ask your genetics team to really have somebody talk to you about the inheritance and what the implications are for other family members, and what you can do for future pregnancies in terms of recognizing whether you're potentially carrying an affected child or not. So again, MPS are a group of rare genetic disorders due to deficiency of specific enzymes. So what is an enzyme? So an enzyme's what I refer to as a biological catalyst that helps things happen. And this drawing here just shows you where you have an enzyme in gray and you have something that binds to the enzyme. In this case, the enzyme can cut that product. It's basically a pair of scissors effectively, but it's highly specific. And so an enzyme, allows things to happen much more efficiently. And all these lysosomal storage disorders are due to enzyme deficiencies where you're missing that enzyme. And here's just another example of sort of that biological catalyst where something binds to the enzyme in gray here and allows this to be now quit and have split and clipped and in two product form. And that's what doesn't happen in this case. If this was a glycosaminoglycan, it should be clipped off at the end, and it doesn't happen. And so this material accumulates in the lysosome and then causes that cell not to function properly, and if continued storage causes cell deaths. Again, I referred to this, these enzymes are required to break down glycosaminoglycans, formerly called GAGs. What are they? So this is just an example of different types of glycosaminoglycans. They're really chains of carbohydrates. And in the body, these chains of carbohydrates, in this case, the carbohydrates are sort of the branching, and the brown is sort of the protein backbone. In this case, you have the carbohydrates attached to these, and the body has to break down these carbohydrates because everything in the body is typically recycled. The body is very good at saving critical nutrients and energy, and so they recycle things. And so I use the analogy of I recycle at home and I put stuff in my garage on a daily basis, and then once a week I can have the advantage of taking it out to the curb and having it taken away. But if you if you put stuff in the garage, but you can't take it away, you keep putting stuff, the bin overflows, the garage gets filled up, you keep pushing it in the garage, and you really then, the garage is no longer functioning. And then you keep pushing stuff in the garage where rotary bursts. And that's the analogy for what happens if you have a missing enzyme, analogy to recycling, if you do that where you live. And I encourage you all to recycle these days. Again, we refer to as lysosome. All this process happens in the lysosome. Again, this is just a schematic of a cell. For those of you who have taken cell biology, there's a lot of different things within the cell. We have the nucleus where the DNA is. We have the energy where the mitochondria. And typically these lysosomes are just very small. There's not a lot of them. You don't see many of them. They do their job very efficiently. But when they don't work properly, you basically get, the cells filled up with storage material. The lysosomes don't function properly, and materials accumulate and causes all the things that we see in patients with MPS and ML2 and ML3. And here's that example on the left, a normal fibroblast, a cultured skin cell. And you can see how you see the nucleus here. And these are all the so-called cytoplasm, the sort of material within the cell. You can even see some mitochondria. And here is a cell with, with a lysosomal storage disorder. It could be MPS, it could be ML2. And you can see all these clear vacuoles, these clear areas of the cell. That's actually distended lysosomes. And when this cell got fixed for this, to take this sort of image it, all the storage material got washed out and left with these clear vacuoles. And you see how overwhelmed this cell is. And certainly you have enough of this, the cell can't function properly. This is a brain cell that really causes that cell not to function properly, or enough it causes the cell to basically burst open and die. So that's that first part of that sentence in terms of overview. These are progressive. The progressive GAG storage causes cellular injury, which is irreversible cell and organ damage. So that's and that results in terms of the MPSs of all sorts of clinical features. And I'll just talk about some of these. We see developmental delay resulting then in cognitive impairment. We can see accumulations of fluid in and around the brain referred to as communicating hydrocephalus. This is more common in MPS 1, 2, 6, and 7, very unusual in Sanfilippo or Morqulo. A common problem that we tend to see in disorders where there's physical disease is carpal tunnel syndrome or spinal cord compression. Again, we see thickening of the space around the nerves in the hand that can cause numbness or tingling, in the neck that can actually cause enough compression of the spinal cord where we see injury there. Corneal clouding is where we see actually clouding of the cornea, so you actually have a very whitish cornea looking if you have significant clouding, and that can have significant impacts on vision. Hearing loss is almost universal in a lot of the disorders, and it can become progressive. Early on, it tends to be high frequency, so even early on, a child may hear sound, but won't be able to hear the spoken word properly. Frequent pneumonias and ear infections, otitis media, is not uncommon because, again, the accumulation of the fluid in the ear, because it can't drain properly due to storage of the gags along the channel where it drains out. Gum, teeth, and enamel are very typical abnormalities in MPSs. Frequent cavities are not uncommon because of the thin enamel. And again, good dental hygiene can really help that, but certainly the abnormal teeth, certainly in the ML2 and ML3 patients, we can see very abnormal gums secondary to that gingival, that the nature of the cell hyperplasia, increased cell numbers, and so that can cause some irritation and sometimes have to be removed by your dentist. Airway involvement, so-called obstructive sleep apnea, is very typical in this population, and one of the hallmarks is really snoring. A lot of times once you have a child who starts to snore, we can do sleep studies to evaluate that, and there's things one can do, and I'll talk about that a little bit later. The heart involvement here is the heart valves. We have 4 heart valves that are basically allow blood to be pumped out, and then they close when the heart refills so it doesn't backflow. And so we can see valvular heart disease in a lot of the MPS, and certainly the ML2 and ML3. The same way with joint involvement, we see joint stiffness, a combination of the thickening of the lining of the joints, the so-called synovium, can decrease function. We can see scar tissue form once you stop moving. And there also can be bony deformity that really limit how much you can do. Enlargement of the liver is not uncommon, with sometimes a little bit of enlargement of the spleen, but we can see this hepatomegaly is referred to as the liver enlargement. And then hernias, both inguinal hernias early on in life for like MPS I patients. It's not uncommon to have their hernias repaired before their diagnosis is even made. And umbilical hernias are also not uncommon and can get very big. And the small ones are actually much more dangerous than the large ones. Even though the large ones have a lot of cosmetic issue, they really don't cause a lot of harm because the intestines can't get trapped in there, where when you have a small hernia, you're at risk of a so-called incarceration. So if you have an umbilical hernia and you can't push it back in place, it's tender, red, swollen, that's a medical emergency. So again, there's a wide range of clinical involvement, both in onset and severity in each of the MPS disorders. And this is a slide I use that virtually, a lot of these patients I've known over the years, some are from the internet, but you can see an adult with MPS II, a child with MPS I, a teenager with Sanfilippo, another Sanfilippo, an MPS I patient, an MPS I, an MPS II, and an MPS IV-A patient, a 6 patient, and an MPS I. So just a lot of variability, which makes it challenging. Another Morqulo patient here, another MPS 6 patient here. One of the challenges we have is early on, the prediction of clinical severity is limited for most individuals with the MPS disorder at the time of diagnosis. With time, we can do a better job. As you allude to, we first talked about Lisa and her son Jack. It was pretty obvious at age 8 that he really had much more of an attenuated form instead of the severe form that she thought he might have had. One of the challenges for a lot of people with the nomenclature, and this is where I won't really focus on much, but historically be aware, Hurler syndrome used to equal MPS. And then there was the Hunter form of Hurler syndrome. And now we have these sort of separate classifications. MPS is sort of the overall, and there's different types. And I can actually date some people how they describe what Hurler syndrome is compared to MPS I. But in contrast, there was a disorder called Shea syndrome, which used to be MPS V, but when the biochemistry came along in the early 70s, people were surprised to realize that it really was very similar to Hurler, and so that became now the milder attenuated form of MPS I. In contrast, for MPS II, we recognize the mild form biochemically before somebody put a name on them, so they're really mild or severe or attenuated. And these days we use the term neuronopathic for severe and non-neuronopathic for the attenuated patients. Sanfilippo, there's really 4 different enzymes that comprise Sanfilippo, where in contrast MPS II and I each have only one particular enzyme defect. All Sanfilippos A and B are much more common than C and D. All have similar clinical pictures in terms of their primary neurologic disease. We see a little bit of somatic or physical involvement, but the overwhelming issue is the neurological involvement. And that same thing applies for the severe or neuronopathic forms of MPS II, and same way for Hurler syndrome, untreated, that causes severe neurological compromise. MPS I, II, and III are by far the most common. Once you get away from those two, Morqulo, MPS IV-A or Morqulo is primarily a bone disorder, even though we can see some heart and cardiac disease. Morqulo B is an incredibly very rare disorder. We no longer use MPS V because it used to be Shea. Meritol-MA or MPS 6 is really a physical disorder where you have intact neurological issues. And SLI is a very rare disorder that looks somewhat similar to MPS I, with both severe forms and attenuated non-neuronopathic form. And we also have MPS 9, which is due to hyaluronidase, which is very few patients recognized in the world with that. So I'm just going to go through briefly through the sort of quickly different pictures of the different MPSs and talk about them. MPS I is deficiency enzyme ironidase. Typically symptoms occur before 6 months of age. Untreated, they die very premature. It's an autosomal recessive disorder. And you can see here, this Chris is 4-year-old at the time, had the typical, large head, big tongue. If you look closer, you have corneal clouding. His arms are bent. He can't really extend them. He has hepatomegaly. He's got some stiff joints, and he's relatively short for a 4-year-old. In this case, he's already intellectually impacted. Allude to the spectrum, initially there used to be Hurler syndrome and then Hurler-Shea, two ends. People recognized early on, years ago, Hurler-Shea thought to be a separate entity. In reality, the continuum, I don't know where Hurler and Hurler-Shea start, or where Hurler-Shea and Shea. We typically refer to severe Hurler and attenuated for the Hurler-Shea and Shea, or non-neuronopathic. But we now know that there can be significant memory issues and other issues related in the Hurler-Shea population. And so it's not so clear cut as we would like to be. It's really, each child is somewhat unique. And again, you can see in the MPS, one patient's cognitive impairment, severe airway, cardiac, heart disease, and they die very prematurely. Where in Shea, we have normal intellect, but can have significant corneal clouding, joint stiffness, can have life-threatening valvular heart disease, and airway disease. Just shows you, pictures of 3 different individuals with MPS I, Hurler, Hurler-Shea, and Shea in terms of how we historically used to classify them. The point is, all of these patients have virtually undetectable enzyme activity. In reality, the Hurler patients have none whatsoever, where a patient like this, who may have half of 1%, but that's enough to spare the brain in terms of progressive neurological issues. As we alluded to, this is a progressive disorder. This is a child with severe MPS I or Hurler syndrome. You can show early on, if you look at her face, you would hard to recognize her. If you examine the rest of her, you would recognize she had it. Clearly at 39 months, it's pretty obvious she has coarse facial features. And most people would make that diagnosis long before the 39 months. Switching to MPS II, again, which is an X-linked disorder, Hunter syndrome. The enzyme deficient is ironate 2 sulfatase. Onset tends to be a little later in the severe Hunter compared to severe MPS I. We see onset between 1 and 3 years of age. They die typically untreated in their teenage years of overwhelming neurological problems superimposed on airway and cardiac disease, where even the attenuated patients can have a shortened lifespan because of cardiac and airway. It's an X-linked disorder. And again, to my knowledge, carrier females really have no significant evidence of disease. And there is a small number of females with Hunter syndrome due to the nature of the genetics, which we can talk about if we need to. And they tend not to have the classic severe form, but can be very involved depending on the nature of what caused their female Hunter syndrome. Again, it's a spectrum. Can't emphasize this more, from severe to attenuated or non-neuronopathic. Age of onset is young. They have cognitive impairment, die very premature, where you can have normal intellect but variable lifespan as the attenuated adult, depending on the airway and cardiac involvement. As we alluded to, Sanfilippo syndrome, there's 4 different enzyme deficiencies that all cause it very similar, where in contrast, MPS I and II have a single enzyme deficiency. The major clinical features are this mental deterioration or cognitive impairment that occurs with time. It can be severe hyperactivity. They have relatively mild physical or somatic features, and unfortunately die in their teenage years in a severe form of overwhelming neurological compromise. Again, severe deterioration occurs in most patients by 6 to 10 years of age, even though we are now aware of some mild forms that sometimes people don't really get diagnosed till they're 20 or 30. And these days of the era of DNA sequencing, much more readily available. I've seen 2 or 3 patients in the last couple of years with Sanfilippo A or B, the 2 common forms, that were picked up, in their 25 to 35 age range because of DNA testing, not because of somebody recognized they had Sanfilippo. But then when you hear their story, that's pretty classic for a very mild form. Sanfilippo patients are normal at birth, slowly, develop normally for a year or two, start to slow down, plateau, and then regress. And hyperactivity can be really a major issue early on in the disease. As they get more impaired, the hyperactivity tends to wane, but still can be significant for some individuals. And they really can survive in a very sort of vegetative state for a long time, unfortunately. This is just a 3-year-old with Sanfilippo, has a little bit of coarse facial features. For those of you who have Sanfilippo children, they tend to have hair that's very unruly and it's very difficult. And so that's just part of the disorder, their wild hair. Just show you some older individuals. They tend to have, relatively mild physical features, but have severe neurological and developmental impairment. In contrast to Sanfilippo, Morqulo, there's 2 different forms, A and B. B is incredibly rare, and I really won't talk about it anymore. A is relatively common, N-acetylgalactosamine 6-sulfatase deficiency. Estimate 1.25 million. Again, a wide spectrum of involvement. Again, the skeleton is the primary organ of involvement with normal intellect, and again, it's an autosomal recessive disorder. A lot of individuals with Morqulo, as seen in these, are in wheelchairs. Partly that is due to they have, in contrast to the other MPSs, the Morqulo individuals have very loose or lax joints. In addition, they're at risk for cervical cord injury, that is spinal cord injury in the neck, and that can result in paralysis or weakness. They also have significant involvement of the hips, which can really make it difficult walking, and the knees in terms of the angulation of the legs. And so it's not uncommon, unfortunately, for individuals with Morqulo to be in wheelchairs. Hopefully with more aggressive medical management, we can avoid some of that, but it's still difficult. MPS III or Morqulo syndrome is due to the enzyme sulfatase B deficiency, has lots of physical disease. Here's a picture. I think this young man was 18 in this picture. He's much older now. Again, he can have severe form. They can die very premature because of cardiac and airway, similar to somewhat MPS 1 and 2. Again, it's much rarer though. And he just shows you that same spectrum in the Morqulo, the Morqulo patients are referred to more as rapid or slowly progressive. Again, it's the same sort of more severe physical involvement versus more attenuated. In this case, there is no neurological involvement. And again, if you examine this individual on the far right there, if you look at him, you wouldn't think he had it, but if you examine the rest of him, he may have some corneal clouding, some joint stiffness, or maybe just a positive family history, having a sibling who's older got picked up and diagnosed. So what are the treatment outcomes in terms of treatment options for MPS? Lots of research going on. You'll hear much more about that later on in this virtual symposium this weekend and next weekend. I'm just going to focus on the 2 that are actually are used currently or were available. One is hematopoietic stem cell transplantation, and it historically used bone marrow as a donor, and now we're typically using cord blood, or intravenous or IV enzyme replacement, where we're giving back the missing enzyme to try to help prevent the progression due to the lack of the missing enzyme. So this is my sort of view of the treatment world for MPS. So in terms of hematopoietic stem cell transplantation for MPS I, the severe form Hurler, it's really the treatment of choice because if transplanted under 2 years of age and ideally under 6 months of age, where we get better results, we can see stabilization of both the physical and neurological involvement. Transplantation comes with a significant risk, so there's minimum of 5 or 10% mortality. For those of you from other parts of the world who may be viewing this, for some parts of the world, transplantation is not readily available, and therefore this is not an option. And clearly, if transplantation is available, they need to be done in a center where has some experience doing pediatric transplants, because these can be challenging. And we know in the US and in Europe, the centers that do it have much better outcome, long-term outcome, than if a center only does one or two. Transplantation is a form of enzyme replacement therapy, and clearly historically has been used for MPS I and MPS VI. MPS II and MPS VI. One of the challenges is transplantation for the brain disease in MPS II and N3A and 3B. Typically is not recommended. Some individuals who are treated very early may have a different response. Historically, transplantation in Sanfilippo Syndrome and Hunter syndrome was done later when there was already significant neurological involvement. It still appears, even if transplanted young, there can be some benefit, but not as much as MPS I. So it's important to make a decision. If we can talk about more of this. There's issues of how to make that judgment, but there's no easy way to do that, especially in a disorder like Sanfilippo, where a child is diagnosed early and because of a previous sibling recognized, and you want to do something. IV or weekly enzyme replacement therapy is now available for MPS I, 2, 4A, 6, and 7. This certainly has dramatically changed for those individuals. Their physical involvement, they're much milder. I've seen a number, because of clinical trials they do for Hunter syndrome. I've seen a number of MPS II patients who've been started under a year of age because of family history, and now are 3 or 4 or 5 years of age, and their physical disease is just so different compared to the untreated patient. Unfortunately, IV enzyme therapy does not cross into the brain, and so it's really not available to treat the neurologic disease in MPS I and 2 or in 7. And some of you in the Sanfilippo community historically asked, why not us? Why not enzyme available for MPS IIIA and 3B, which are each one, A and B, are just as common, or not more common than some of the other MPSs. And the really reason is that given IV enzyme, it doesn't cross into the brain. And so therefore, the physical disease is relatively mild. Yes, you may benefit a little bit, but companies would have a very difficult time getting approval of an IV enzyme, because it's really hard to show a significant stabilization of disease. But the hope is for the Sanfilippo and some of the other neurological diseases is that either taking the enzyme that's missing and modifying it so it crosses the blood-brain barrier, or so-called gene therapy. Those are actively now in clinical trials for some of these, that may be an approach for the neurological disease in the future. So with that, I want to sort of thank everybody for the attention. We have plenty of time for questions. That was my goal. I hope Lisa could come back on now and sort of now start asking questions. Again, please, no questions too simple, too challenging. If I don't know the answer, I'll tell you that. But again, thank you for your attention, and I hope you enjoy the rest of the meeting. There's a wealth of information available to you. Thank you, Lisa.
So I believe we have a few questions here in the chat. We have about 8 minutes to get through a few things, so we're going to rapid fire here. And there is a question, Dr. Muenzer, on talking about a research on clinical RT crossing the blood-brain barrier. What are your thoughts? I know you're very familiar with that one.
So again, I missed the first part of the question. Sorry, Lisa.
It says, from my research, there are clinical trials for ERT crossing the blood-brain barrier. What are your thoughts on those?
Yeah. So what they're referring to is they're taking the enzyme and coupling it. For example, I'm involved in MPS II clinical trial by Denali. They're taking the MPS II enzyme and coupling it to an antibody that recognizes a receptor, in this case, the transferrin receptor on the blood-brain barrier. So those have, early on, they have potential showing that the really enzyme does cross over. And so, again, it still requires weekly enzyme, but hopefully the enzyme therapy now will treat both the physical disease and the brain disease. So this is sort of an exciting opportunity in the future. There'll be another company, JCR, which already has approved this type of therapy in Japan for MPS II. They may be doing trials in the US too. So there is hope that we'll see enzyme therapy that may help the brain disease. It's still not available for everybody yet. It's still in clinical trials, but I'm encouraged about it.
Thank you. Someone asked if a carrier of an MPS disease passes the gene to more than one child, is the severity the same?
So the gene doesn't change, even though you may pass it to more than one individual, but within a family, for example, within an MPS I family, we tend to see, if you have more than one child, we either see the severe form or the attenuated form or the intermediate. So it does not change severity. But depending on which genes are passed on, we can see different forms. For example, some of the patients with MPS I who are attenuated have one severe gene and one attenuated gene, and that attenuated gene makes a little bit of enzyme that allows them to have a milder form.
Someone asked if there's any benefit to diet at all that can help with these.
The only benefit is a healthy diet, a healthy lifestyle to make kids stay active. Enzyme, what you eat does not affect what you store, so diet does not impact. But we know that in some forms, like some of the severe Hunter syndrome patients, they love to eat. There's a lot of oral satisfaction they gain by eating, and so obesity can be a significant issue for some. So a healthy diet, watch what they eat, be aware of calorie content, and try to have the children stay active as possible.
Along those lines, someone asked about GAGs and mentioning that you said, Dr. Muenzer, that GAGs are carbohydrates. Does the body get these from certain foods, or are they produced by the body? So
GAGs are carbohydrates. They're really repeating chains of particular sugar molecules, so there are carbohydrates, but the body makes them. Doesn't matter what you eat. You can't sort of change how you make the GAGs. We all make GAGs, and we all break down GAGs. It's just that MPS patients are missing the enzyme to break them down properly.
Here's a question regarding developmental delay. If we have developmental delay age 5 on the level of 2 to 3 years, sounds like cognitively with MPS II, does that mean it's severe?
Unfortunately, yes, because you already have significant delayed development. But not everybody has the same degree of involvement or rate of involvement. What I say is that if a child goes to school, to go to kindergarten or first grade and it's age appropriate at 5 or 6, I've never seen the severe form occur. They always, at that point, stay intellectually intact. They can have some subtle problems. But when you have a child who's already 2 or 3 years delayed, unfortunately, that's neurological involvement, and that's unfortunately the neuronopathic or severe form.
Here's a question as far as clinical trials. As far as possible clinical trials go for MPS II, which path do you see having the most potential? The weekly ERT crossing the blood-brain barrier or one-time gene therapy? This is $1 million question, right?
That question really can't be asked until we see the data. We haven't had enough experience with gene therapy to see the data yet. This data has still not been really published in detail. I'm involved in the IV ERT trial for crossing the blood-brain barrier. That looks encouraging, but again, we have to really see the data, and time will tell. And so right now, it's really difficult to answer that question, which is going to work better. I'm going to be doing also an IV gene therapy trial down the road. Each have its limitation. Not everybody's going to be eligible for gene therapy as we do it, because some people have antibodies to AAV, pre-existing antibodies. That's a whole nother talk, which they may get later on in the meeting, I think, Lisa, won't they?
Yes, there is on clinical trials, so check that one out. Here's someone who's a 25-year-old with MPS VI and curious about the success rate of stem cell transplants.
Stem cell transplant is a form of long-term enzyme replacement therapy. It does work, but the issue is that has a significant mortality at age 25 or so. I'm going to predict the mortality from transplant would approach 20%. The older you get, the greater the risk for stem cell transplant. One, you have to have the appropriate donor. Even with the ideal donor, HLA matched sibling who doesn't have it, it still has significant risk. So it's an option if you have no therapy, but it's a significant option in terms of the risk associated with stem cell transplant for MPS VI in an adult.
Here's a question regarding spinal stenosis. I've been told I have spinal stenosis, really don't want to have surgery. Are there other treatment options there?
So again, spinal stenosis is where the covering around the spinal cord, called the dura, gets very thickened, and it can get thickened enough to actually compress the spinal cord. So there's varying degrees of spinal stenosis or spinal cord narrowing. There is no treatment except surgical treatment. And again, if you wait too long, you can have permanent injury to the spinal cord, but it's also a very invasive procedure. So it's really working with your neurosurgeon, working with your orthopedic person to come up to the right time that's appropriate.
If a child has normal enzyme, does this mean they are not a carrier?
If they have absolutely normal levels, yes. But the caveat is that the diagnostic labs that they use for measuring whether you have it or not are really designed to picking up deficient and not affected. Carriers are not affected, so carrier using enzyme is not ideal. It's much better to DNA than to assume that a normal enzyme you're a carrier, because sometimes in MPS II, for example, you can have relatively low levels and still be not a carrier.
Thank you, Dr. Muenzer. We do have some other questions. We will try and get these answered, and I encourage everyone, if you didn't get your question answered, there will be other sessions where we will be covering some of these items as well that you should be able to ask them again, but if not, we will try and get some answers out as we publish information on the conference. So with that, we're going to end the session, and again, thank you, Dr. Muenzer, for your time today. As always, we appreciate you very much.
Thank you, Lisa. Have a great day, everybody. Bye-bye.